Good afternoon, good evening, and good morning to our audience from Asia. My name is Jianan Yang, and I'm the postdoc fellow at the Asia House Policy Program here at the Shorenstein Asia Pacific Research Center. Welcome to today's PKU Stanford Joint Webinar on Asia House Policies. And today we are delighted to have Dr. Toshiaki Iizuka here talking to us about a classic textbook problem of market failure, the tragedy of the commons in the context of emergency medical services in Tokyo. Dr. Iizuka is a professor at the Graduate School of Economics, the University of Tokyo. His research interests are in the field of health economics and industrial organization. He has written articles on incentives and information in the healthcare markets, which appeared in leading economic journals, including American Economic Review, Red Journal of American Economic Journal, Applied Economics. Dr. Iizuka currently serves as the associate editor of the Journal of Health Economics and is also a member of the Central Social Insurance Medical Council, a council of the Japanese Health Ministry that determines provider payments and drug prices. He holds a PhD in economics from the University of California, Los Angeles. Dr. Iizuka has worked on a range of very important issues related to the healthcare sector, such as agency problem among physicians in drug prescription, patients' reactions to changes in healthcare pricing, and chronic condition management, just to name a few. As a big fan of Dr. Iizuka's work myself, I'm thrilled to hear about his latest research today. He has also been here with us at APARC as a visiting scholar a few years ago. So Dr. Iizuka, welcome back.
Thank you very much for having me today. I'm delighted to be here, back to Stanford with nice blue sky. Right, so again, my name is Toshiaki Iizuka. And so this topic is the tragedy of the commons in emergency medical service. And this is a joint work with Shunta Hagiwara, a PhD student at the University of Tokyo. This is a quite preliminary study, and so I'm very much welcome your comments and questions. Right, so the motivation of the study is that concerns have been raised by many scholars and medias and journals that emergency medical services are often abused. So for example, people visit emergency department for primary care, like use ambulances as free cabs. And so these might be individually rational, but it may delay the use by others and lowering the chance of survival of those people. So the agency often urge proper use of ambulances, saying that to save lives that could be saved. And from economics perspective, these concerns are quite relevant because these services are often not excludable, and there is rivalry in consumption. So in other words, they are commons, a common resource pool or natural resources, and in economics words. So these are kind of one of those examples of commons problem, but in our view, relatively little is known about the extent of the negative externality. So when I teach like elementary econ classes, we always talk about like externality, and that there is a difference between private cost and social cost, and we draw like a demand and supply curve, and there's a shift and like a difference between the two lines, and we say, oh, this is the externality. But I always wonder, how much it is, and so we never know that distance. So this is an attempt to, quantify it to some extent. Right. So this paper, we study the extent of the commons problem in the context of emergency ambulance services in Japan. So we ask, what is the social marginal cost of calling an ambulance on others in terms of arrival delays and survival rates? And emergency ambulance service we discuss may face a commons problem in Japan because anyone can use them for free and no one is excluded. And there might be rivalry in consumption because capacity is limited. So what we do in this paper are threefold. So first, we estimate the relationship between the number of available ambulances and arrival time. So here we look at the relationship by whether like a fewer ambulances available leads to arrival delay. So that's the kind of first relationship we estimate. And the estimate indicates the extent of the negative externality. And the second estimation is to look at the effect of arrival time on the arrival rate. So we focus on cardiac arrest patients for this study. So the second one is to look at the outcomes of arrival delay. The first one is whether a congestion actually leads to the delay in arrival. And then third part we are working on right now is to analyze the impacts of like a policy remedies possible. So one is to address, well, both of them try to address the potential problems of our commons program. The first one is to make ambulance use excludable because excludability is one of the main characteristics of the commons problem. And for this, we perform triage to limit the use by minor cases. And the second experiment is to reduce rivalry in consumption because there's a rivalry in consumption that leads to arrival delay. And for this, we simply increase the number of ambulances. There are a lot of literature related to this study, and theoretically very well-known studies like Gordon, Hardin, and Ostrom. All of these like classic papers look at the issue from theoretical perspectives. And there are many applications in the natural resource economics. And also in the healthcare, there are discussions about the emergency department crowding. And also there are a lot of studies about the negative externality of traffic congestions. And also in the medical literature, studies have looked at the relationship between ambulance arrival time and mortality. So all of these are related, but we attempt to add to the literature by estimating what I just said, like a social marginal cost of consumption rivalry. So this might be our, this is our contribution to the literature. So let me just talk a little bit about the background information about emergency medical service in Tokyo. In Tokyo, fire departments provide emergency ambulance services for free. No one is actually excluded from using it. And so just for your information, if you come to Tokyo and have some problems, you call 119 and not 911. Okay, so that's the number to call. And entire Tokyo is covered by one fire department, except for a few remote areas. And fire department only receives and responds to 119 calls within its jurisdiction. So these two characteristics are useful for our analysis because the market boundary is clear. So in our study today, we just focus on Tokyo, and then it's a gigantic one market, and then there's a clear boundary, and so that's going to be useful for our study. And also, private ambulance services are quite rare. So almost entirely emergency ambulance services are provided by public sector. Regarding the ambulance crews, crews commonly work 24 hours from 8 a.m. to 8 a.m. the next day. Of course, they do have some rest time during those hours. But this means that same number of ambulances is available 24/7. And so if there are some delays in arrival, they are likely to be driven by demand factors. And because the supply side is almost fixed. And we look at the 2019 data, and then for that, 267 crew units or ambulances were operating 24/7 in Tokyo. So that's the maximum available capacity from the supply side, but there are a lot of ambulances used at some point, and then that's going to reduce the amount of available ambulances. And a bit about detail about transportation. And so when a fire department receives a phone call, then there's a central command which orders the fire station closest to the scene to dispatch an ambulance. And if the closest one is not available, then the next closest one will be dispatched. And the next closest one is not available, then the next one will be dispatched. So there's kind of a domino effect here. And so if there are a lot of ambulances are called, then it is likely that that ambulance is going to come from the distance. So it's going to be delayed to some extent. So that's kind of the mechanism we have in mind in terms of the relationship between the ambulance calls and the arrival delays. And at the scene, the crew will provide first aid and loading the injured and sick in ambulance. Then the captain calls and finds a hospital that accepts the injured. This is a bit different from US style, I believe, because in Japan, very few hospitals have dedicated emergency physicians. So instead, like on-call physicians who have some particular specialties actually provide emergency care. So the captain must make sure that the hospital actually can accept the patient and then treat the patient. So it takes some time for them to sort of find out the hospital. And then after finding the hospital, the ambulance departs for the hospital. So we have we use two main data sets. And the first one is the ambulance transports data. So we observe the universe of ambulance transports in Tokyo. We use 2019 data for this analysis, and which includes over 730,000 observations, and which is provided by Fire and Disaster Management Agency. And for every 119 calls, we observe detailed transport time, including like dispatch command time, site arrival, departure for the hospital, and the hospital arrival, and when the injured is handed over to the hospital. After the patient is handed over to the hospital, it takes usually about 22 minutes to prepare for redeployment, so to clean up the ambulance. And then after 22 minutes, the ambulance is ready for redeployment. So that's how we calculate the number of available ambulances at the time of one's phone call. And in addition to those detailed transport time, the data also includes accident type, as well as characteristics of injured sick. And one of the variables we use is interesting is severity of the injury, and like minor, moderate, severe, and death, and which is assessed by the initial hospital physician. And in the Japanese case, we're not sure exactly yet, but it seems there are a lot of minor cases, which consists of more than 54%. And later, we have some counterfactual to reduce some of those minor injuries by triage. And so that's the data coming from. So minor means that there's no need for hospitalization.
Can I ask real quick about like a clarifying question?
Sure.
So after the 22 minutes, will the ambulance return to a closest like fire station, or they can just depart directly to the next scene?
Yeah, they can depart to the next scene. This is actually, I have more information about what you asked. So this is ambulance transport on average. So the dispatch command, site arrival, depart for hospital, and hospital arrival, and hand it over to the hospital. So we observe these dead start points in the data, and then it takes about 8.6 minutes to arrive at the scene. So the main focus of the study today is this time, actually. And then after the patient is handed over to the hospital, as I said, it takes about 22 minutes to prepare for redeployment. And then after that, they actually depart for the fire station. But as I just mentioned, they actually can go to the next mission from here without returning to the fire station. And it takes about 69 minutes on average for one mission from the dispatch to when it is ready for the next mission. So that was the first data set. And then the second data set is about the health outcomes. So for this data, we have some information about survival, which is useful. But the data set is only for cardiac arrest patients only. And the data set is called the Utstein style data, and which is pretty a common format across nations. But it has only about 12,000 cases per year compared to 730,000 transport for the entire, which the number of the observation here is much smaller. So to arrive at the relationship between the health outcomes and then arrival time, we now use 10 years of data for this one. And then we only have the health outcomes are again available only for these patients. But these patients actually consist of 1/3 of severe or worse cases. So they are the main sort of, so one of the most critical, time-critical segments. And outcome variables we use right now is the 1 month survival rate, which is 1 month survival, which is about 5%. And so they are very severe cases. And then 1 month favorable neurological survival, which is 3%. So they are survived and then neurological intact ways. So let me show you some data points here. So this is the ambulance transports and then per day by date in 2019. So we have about 2,000 ambulance transports per day. And then more transports we have during summertime. There's some seasonality and winter time here and here. And if we look at the data by day, by hour of day, and so we have hour of day here starting from like a midnight, and then the y-axis is average ambulance transports per hour. So what we see here is that in the really early morning, the transports are very small, and then it increases. So this line is 8 in the morning. It picks up like 9 in the morning. It's the number is the highest, and then during daytime there are a lot of transports and declining towards the evening and midnight. This is the frequency of ambulance transports per hour by daytime and nighttime. And daytime is the red ones. So we see like a mode is about 90. So per hour, on average, like 890 transports we observe. But during the nighttime, which is defined like 8 p.m. to 8 a.m., we have about 40. That's going to be the mode of the transports. Ambulance transports per hour are higher during the daytime and than the nighttime. And the next plots show the relationship between ambulance availability, which is the x-axis, and arrival time. We have a total of 267 ambulances, as I said, and then the number goes down, decreases, and then we tend to see the arrival time is going to be delayed. So that's the relationship in the raw data. So if we compare this point to the highest point here, it's about 4.5 minutes during the peak hours. And if we see the nighttime and then daytime separately, we see that often no rivalry exists during nighttime right here. So even if the available ambulances are decreasing, still there's no increase in arrival time around here. So often no rivalry exists during the nighttime. So just give you a little bit more about the statistics. So for this ambulance availability, the mean is about 160, somewhere here. Standard deviation 32, the minimum is 23, and the maximum is 244, and somewhere here. This was the first relationship we're gonna estimate later. And then the second relationship we're gonna estimate is this one. So this is just simple data, but the data shows the relationship between arrival time and survival rate. So the arrival time is on the x-axis, and then y-axis is the survival rate. So generally, there's like a negative slope, although we have few observations here, so it's a little bit noisy. But we have 4 figures here, which is divided by whether CPR is performed, yes, and there was a witness of the incident. So when there is a CPR is performed and witness exists, and then the survival rate is much higher, like here. Although arrival rates, as the arrival takes time, then it generally goes down. But if CPR is not provided, then the survival rate is much lower, and it seems negatively slow, but there are a lot of noises here. And then if there's no CPR, and yes, CPR, but no witness, so the incident was not witnessed by anyone. And then even if a CPR is provided, then the survival rate is quite low. And if no case, that's very likely the person is going to survive. So this is the raw data. So now we estimate the 2 regressions as I just discussed. So one is to estimate the impact of the available ambulances, so number of available ambulances here, and then its effect on the arrival time. And we also include like attributes of the incidents and also time dummies, like hour, day of the week, holiday months. And we also include the half-day fixed effect, which means we are looking at 1 year, so about 730 dummy variables included. And so this is a simple like linear relationship, but we also estimate a non-linear model in availability. Identification issues issue we are concerned right now is there might be some unobserved factors that may affect both the availability of the insurance as well as the arrival time. So one thing we concern is something like a local festival. So let's say like if you have a summer festival, then you might have more injuries and accidents, and then you have more 119 calls. So availability is going to be affected. But festival might also affect the local conditions like local traffic jams, and then that might lead to the arrival time. So we need to address it. And the solution we have right now is to include a half-day fixed effects. So again, like including 365 times 2 fixed effect per year. And so that means we exploit sort of like a half-day within half-day variation. So we have half-day fixed effect, but still there are a lot of variations within the half-day in terms of available ambulances. And then we try to see its effect on the arrival time. So that's the solution we have right now. And the second regression is the health outcomes regression, which is to estimate the effect of arrival time on survival. Okay, and again, this is just for the cardiac arrest patients. And we estimate this model by the 4 groups separately because they appear to have a different slope. So we will estimate them separately. And we have arrival time and then survival rates, including and attributes of the transport and time dummies. And right now, this is just OLS, but we plan to instrument for arrival time here because there might be some endogeneity, like for emergency, like urgent cases, the crew members try to reach there as quick as possible, and then that might also affect the survival, which is in error term. So we try to instrument for that. And this is just arrival time on the right-hand side, but also we include the other times after arrival to the hospital arrival. So between the site arrival and the hospital handover in the right-hand side, and try to look at the results effects. But so far we have nothing at all, and so basically focusing on this time. Just I tell you the results, show the results of the first regression. So again, that was the effect of ambulance availability. So how many ambulances available and whether that's going to affect the arrival time, and using the linear model. And what we find that there is a kind of negative relationship. So we find rivalry in ambulance use. So once ambulance call delays arrival for others by 0.03 minutes, which is about 2 seconds. So if you make a phone call, then someone next to you will, on average, get the ambulance from a little bit farther distance, and that's going to lead to the 2 seconds delay. So it seems very small individually, but on an aggregate level, the impact is not trivial because the making phone call is not just me, but also there are other people actually making a phone call at the same time. So one standard deviation in the average ambulance availability is about 332. And so therefore, it's going to lead to like a 1 minute delay. So we will try to see how important is the 1 minute delay next. But before doing that, I would just also estimate a nonlinear model. So results from a nonlinear model. So for this one, we replace the availability we had in the regression by bins of 5 ambulances using the base category is like greater than or equal to 230. So we don't see the base category, but base category is somewhere here. And then after that, we have bins of 5 ambulances for each of these units. So these are just like a dummy variable corresponding to the number of available ambulances. So what we see here is that as the number of ambulance available decreases, so this is decreasing this way because this is the number of available ambulances, and then we tend to see larger arrival delay as we see. So this is almost like the same as we actually plotted initially in the raw data, but that's what we see in the nonlinear model. So compared to a non-library case around here, up to 4.6 minutes delay may exist during peak hours. And again, there's no rivalry when fewer than 210 are used. So there are some areas there's no rivalry at all. And then next one is to estimate the effect of arrival time on health outcomes. So we estimate the model separately for each group. Again, this is just a linear specification right now, but we have 4 different groups, whether there was a CPR, I said a CPR, actually this was a bystander CPR, and whether there was a witness. So we have 4 different groups and then estimate the effects of arrival delay on survival rate. And if we estimate, we find that the 1 minute arrival delay leads to 0.66 percentage points decrease in survival rate. And then the impact is going to be different because as we saw, the slope was different in the raw data. So basically, these numbers capturing slopes. So once again, 0.66 percentage points, they are statistically significant at the 1% level. But baseline survival rate was actually around 5%. So compared to this one, like the change in survival rate is quite substantial. So 1 minute delay leads to 0.66, and the base is only 5%. So it's like a 13 percentage change. So that's quite a big impact. Okay, so for the rest of the paper, we look at some sort of policy counterfactuals. So again, like we have a commons problem, and the excludability and non-excludability is one of the characteristics of the commons problem. So we try to look at what would happen if like EMS, emergency medical service, can be excludable. And for that, we consider triage. So triage is to prioritize urgent uses. In other words, like they do not transport everyone. And in Tokyo right now, triage is rarely performed, and only about 400 cases in 2019 out of 730,000 transportation. So almost everyone is transported. But in other countries, like triage is performed, and then in the case of UK, for example, they transport only about 63% of all calls received. And then, so this is right now, we are benchmarking with this number. To do the policy counterfactual, we follow the following steps. So first, randomly triage a certain percentage of minor cases. As I said, there are some minor cases in our data, and which will increase the available ambulances because the transportation is going to be reduced. Then that will increase the available ambulances, and which in turn will shorten arrival times. So that was already estimated in the equation. And then if arrival times is shortened, then it's going to increase survival rate, which is also estimated in the equation. And right now we have results up to here, and then we're gonna do the health outcomes analysis later. And so this shows the impact of triage on arrival or time. So for this one, we consider call triage that reduces minor cases in half. So randomly drop half of those minor cases from the data set, which reduces the number of which increases the available ambulances and then reduces the arrival time. So half sounds really drastic, but roughly equivalent to that of the UK's current situation. But we have to scrutinize the number, of course. And if we do that, this is the distribution in terms of the reduction of arrival time. And sometimes reduction of arrival time is like close to 0, and like 1 minute, and on average about 0.65 minutes. So that's the magnitude of sort of drastic triage will lead to. And the impact is actually larger during the daytime. And the second experiment is to increase capacity. And here we increase the number of the ambulances, which will mitigate the rivalry in consumption. So for this exercise, we increase the number of available ambulances by 20 in the figure I showed next. So this is going to shorten arrival times and will increase the survival rate. And so this shows the impact of increasing the ambulances by 20. So if you increase the ambulances, then that's going to reduce the arrival time. and somewhere here about like the 0.5 minutes. And if we calculate on average, adding 20 ambulances shortens arrival time by 0.45 minutes. And so we're gonna next try to look at the effects on the survival. But so far we compare the two policies we just have. Then they look like this by hour of the day. So like midnight, early morning, and in the morning and afternoon. And the y-axis shows the average decrease in arrival time during that hour. And then blue dots show the effect of triage, and then red dots show the increased capacity by 20. So one thing we can see from here is that, well, maybe it is expected, but like early morning, we have the impact is much smaller. This means like arrival time will not be affected that much. But during the daytime, the decrease in arrival time is like minus 0.6 and minus 1 because of there are a lot of ambulance transports during the daytime and congestion is severe. And so that's one of the reasons why we don't see many impact here, but a lot more here. So a natural implication might be, implementing policies in these time periods would be probably useful. Like if they add increased capacity, it doesn't really mean much to add capacity during the midnight. Rather, just focus on adding capacity during the daytime would be sufficient reasonably. So next step is going to calculate the impacts on the survival rates. Right, so that's the results so far. This is pretty preliminary, as I mentioned, but the conclusion is that, so the first part, we find evidence of a commons problem in EMS, and the individual irrational ambulance calls that people make, that's going to delay the arrival of ambulances for others. And the impact seems quite small individually, but combined with all others, creates a substantial delay. And the arrival delays result in lower survival rates. And so this is something like the distance of the shift, what we estimated. It is not perfect, but that's the extent of externality. And the rivalry effect is nonlinear and large during the daytime. And triage and increasing capacity we implemented appear to alleviate the commons problem, especially during the daytime. So we're gonna, next step, try to look at the effects on the health outcomes, like survival rates, and try to come up with some sort of a cost benefit kind of ideas. So that's it for today I have. So thank you very much for listening. And again, the comments are very much appreciated.
Thanks. Thanks, Toshi, for this very insightful and thought-provoking presentation. So I'm thinking about the policy exercises that we did at the end of the presentation. So can you give some intuition about why triage seems to be more effective than increased capacity? Because remember in the graph, we see that like during the daytime, there's some gap between the two policy counterfactuals, right?
Yeah, I think the level itself is not quite relevant in a sense, like we do not control for the level itself. And because like it's just a comparison between the reduction in the transport by the first one, I mean, the triage is actually 50%. So it seems like simply this is a greater impact than like increase in the capacity of by 20. And certainly if we increase capacity more, then the red dots actually approaches to these blue points. So the difference itself is the sort of the level of experiment we right now specified. So another thing we thought about is like the patterns of the change might be somewhat different. So that might be something due to the different kinds of the experiments we have. So in terms of blue one, like a triage is focused on the minor injuries. And then capacity is just increasing capacity, and then nothing to do with the level of the severity. So so if the distribution of the severity is kind of different by time, and then that might actually affect some shape of the impact. So we have to look at this one a little bit more carefully, but it seems like there's a lot of decline here in the triage case. But for this one, the decline is not that big. So maybe for this one, in this area, there are a lot of minor cases, so that might actually be improving the arrival time or something like that. So maybe the shape might be more relevant rather than the level. So that might be, yeah.
Yeah, that makes total sense. So actually, I was also thinking about how the kind of like cases are distributed differently across a different time of the day, right? For example, during the night, probably there are less accident, but there might be more like those the elderly with heart attack or things like that. And during the day, there might be more like accidents involved, and this might have some implications of
Yes,
the effect of different policy tools.
exactly, right. So
Yeah.
for example, like even during the daytime, on the weekends, maybe there might be fewer like hospitals and the clinics available to patients. And then people may actually call ambulance because they do not have access to other medical facilities. And in those cases, there might be a lot more like minor cases using those ambulance services. So that kind of things we might need to do like by just not just a hour of day, but we should also weekends and holidays and so on.
Right. And also for you control for a half day fixed
Mm-hmm.
effect, right? And the
Yes.
half day, I guess, is like 12 a.m. to 12 p.m. Is that how we divide it?
Right now it's divided between 8 a.m. to 8 p.m.
Oh, I see.
Yeah.
Yeah, I also feel that kind of like makes sense in terms of the distribution of cases we see across the
Mm-hmm.
day, right? From the graph that you showed us earlier.
Right.
Yeah.
Yes.
So yeah, so now we do have like a question from the audience, and the question is about how might the witness contribute to the survival rate? For example, are they helping to call the ambulance, or are they doing something else?
Right. Yeah, so we had a graph about witness. I think yes, I think that's right. So witness, if there's a witness and then they will call the ambulance, and that's one thing. And then also, well, that's my guess, but many cases like here, unfortunately, people are not witnessed if they have a cardiac arrest during the midnight, and then they notice nobody noticed the cardiac arrest. So that's kind of a thing. And then after several hours, somebody noticed it, but it's not counted as a witness. So then it takes quite a long time before the person is treated. And then as we see, even if there's someone witnessed and then CPR is performed, like there's a critical like moment somewhere here, like after 20 minutes, almost there's no chance. So if somebody had a cardiac arrest during night and nobody noticed, that's unfortunately there's no chance in those cases.
Toshi, I think we have Now, another question from the audience, which is also asking about the two policies that we're considering here. The question is, will the two policies cause different effects? Like people will call more because of like the increasing capacity, but call less when knowing that there is triage over there.
So the question was about cost of the providing the policies.
I think like feel free to correct me if I understand the question wrong. So I think it's a question asking how will the like people who call for the ambulance respond differently to the two types of policies? Probably like the triage is discouraging those like who call for a minor cases. Do you think there will be kind of like a demand side response to that?
I see. Yeah. I suppose I'm not I haven't thought about it actually. Yeah, so that's something I need to think about it. Yes. So the just increasing capacity will not change the expectation of the caller, I suppose. Yeah. And then if there's a triage, and then whether it's going to change the behavior of the potential callers. Well, I think that's a great question. So yeah, I think we need to think about it.
Actually, I would like to follow up on that too, because I was also thinking about like the type of like policies we can potentially thinking about following your finding. So I think what we find over here is that provision of this free emergency ambulance services creates some misallocation issue, meaning that those who need it most are not getting the service in time, right? And like I know you have also worked on the like whether the zero price is special in the domain of childcare, and basically those both highlights the importance of this trade-off between affordability and moral hazard in healthcare utilization. So do you think like probably the price will be a possible solution in this case? For example, we can like condition on the severity of your illnesses. Probably for minor cases, like you can charge a price or something. Do you think price mechanism will work in this case?
Yeah, I think that's a very important question, and then often discussed even in Japan. And so the one thing is to charge the ambulance services, and according to the cost side estimates, some people say like a one ambulance transportation costs around like $200 or maybe $300 or something like that. So that's the cost, and then people may think about how much to charge. So charging price is definitely one way to exclude the service usage, and then that will be definitely reduce the utilization. But the debate is whether we should charge is about maybe some people may not know whether actually a minor they have a minor cases or like severe cases, and then even emergency group members may not be perfectly be able to predict it. So if you just charge prices, then there might be some concerns about those who needed the transport actually do not call the ambulances. But still, there are many, actually majority of countries actually charge prices for ambulance services. So definitely one option to do that. But in our experiments, I think we thought that's a bit difficult to implement because we do not know the sort of elasticity of the price elasticity of the demand for if we charge. And also it is a little more, again, like those who needed more maybe not using the services but we don't really know the consequences. So instead, we just look at the triage right now because and it would be more reliable if the emergency medical service personnel to judge whether the service is needed or not. So that's something maybe easier to step in for when there's no exclusion of usage like in Japan. Yeah.
Yeah, that makes total sense. I think we know that in healthcare settings, probably sometimes the price is not like a very useful screening mechanism in terms of screening out only the low quality care as opposed to not screening out the high quality care, right? And for something as important as the emergency like services, we don't want to exclude people who really need it.
Yeah,
okay,
right.
so
So again,
yeah,
like if you charge it, and then definitely that will reduce the utilization,
right,
but maybe not selectively as this people may wish to. Like
yeah,
sicker people we want to use, and then minor people we don't want to use, but we're not sure that's going to be the case. So yeah.
right, yeah, totally. Yeah, so we have another follow-up question regarding the witness classification. I think the question is about when there is like a CPR performed, but there's no witness. Would that mean the CPR is performed by the EMT after the arrival of ambulance? In contrast, would the witness be able to perform the CPR prior to the arrival of the ambulance?
Right. So witness means like a witness of the incident. So when like somebody had a cardiac arrest or heart attack, and then witness, yes, means someone saw it, right? But after someone is actually is lying down, and then people may actually come and approach and then perform CPR. So that's the case. CPR is yes, but the witness is no, for example, right? Or maybe after in the morning, like unfortunately you found someone had a heart attack, cardiac arrest, and then nobody witnessed the incident, but people might perform CPR. So that's the yes and no case. Yeah.
Yeah, thanks for the clarification, and I hope this resolves the question from our audience. With that, I think we are about at time. And I would like to thank Dr. Iizuka again for this fascinating presentation on this very important issue. And I would also like to thank all of our audience for joining us here today and for your participation, and hope to be in touch with you for future webinars.